Hello, and thank you very much for the invitation today to talk a little bit about fluorescence-guided surgery and its role in improving lymph node identification. My name is Manish Chand. I am Associate Professor of Surgery at University College London. So this was something I was thinking about a few years ago when we began to see the popularity of fluorescence-guided surgery, and in particular, its use in colorectal surgery. And the possibilities in my mind around fluorescent-guided surgery at that time far exceeded that of simply bowel perfusion. And I came up with this quote and this slide, and I likened it to using your iPhone to making a telephone call, because there's so much more that we can do with fluorescence-guided surgery, and so much more that we're going to begin to see over the coming years. In nodal disease, or the identification of lymph nodes in colorectal cancer, we can apply fluorescence-guided surgery in different ways. We can look for sentinel nodes or aberrant nodes outside the normal resection margin. We can look at lymphatic mapping. We can try and target specific nodes that are difficult to identify in normal circumstances, such as those in the pelvic sidewall. And we can combine it with other technologies, including augmented reality or even radio-guided surgery, to try and get this symbiotic relationship to better identify and make our surgery more precise. It's really all about understanding this triad of factors: the fluorophore, or the dye, the anatomy, what you're trying to look for, or in some cases, the pathology, and then access. Are you going to give this intravenously, or are you going to give this interstitially? And it's manipulating these three factors that allows you to target specifically. So let's get back to colorectal surgery, and in particular rectal cancer surgery. We know now for many years that if you do not undertake good total mesorectal excision surgery, you render the patient at risk of a high rate of local recurrence. And the reason is, if your surgery involves the red line and you leave elements of the mesorectum behind, you are hypothetically leaving some nodal disease behind. And it is this nodal disease and this mesorectum that leads to increased rates of local recurrence. So if you perform a proper TME, you are therefore not leaving any mesorectum or nodes behind, and you are putting the patient at best chance of survival in relation to local recurrence. This is not the case with colon cancer, because there's no universally accepted way to undertake colonic surgery. And colonic surgery differs depending on whereabouts in the colon the cancer is. So we can see that there's a variable rate of local recurrence. We're not really decided on universal consensus in flexure tumors. And when I say flexure tumors, it would be more specifically splenic flexure tumors. And also, what do we do about these central lymph node metastases? When we look at survival over the last decade or so, we can see that those cancer resections that are in the IMA territory are doing better than those in the SMA territory. So there is something in all of this. And the challenges are that there's no standardized surgery in colon cancer, as there is in rectal cancer. There's no clear understanding as to the lymphatic node patterns and what type of lymphadenectomy we should be doing. We haven't decided on radicality, and we have not used technology in a way to better identify lymph nodes than using simple cross-sectional imaging. So when we looked at the data, and this is a paper from Liberale and colleagues that looked at the use of indocyanine green, the most popular fluorophore used in colorectal surgery, and detection of sentinel lymph nodes, we found that of all the studies reviewed, there was huge variability in the sensitivity, huge variability in the specificity, and huge variability in technique. And there, if you've got this type of variability and heterogeneity in the data, of course, you are going to see a whole variety of different outcomes. So it becomes meaningless, really, as an analysis. What we tried to do is we tried to, rather than look for sentinel lymph nodes, look at lymphatic mapping. So inject tumors directly, and by injecting tumors directly, identify the lymphatic pattern and where that tumor is draining to. We also looked through the records ourselves and did our own systematic review. And what we found is that if you do not have a universal technique when it comes to either administrating the fluorophore, reading the signal, deciding where you're going to put the dye, you're going to get a whole load of variable outcomes. And that's what we found. So one of the first things we suggested is to try and standardize the technique and inject the ICG in 4 sites around the tumor, and then wait on average 5 minutes or so that we can see the lymphatic drainage. So we do this either at the beginning of the surgery, if we're doing it laparoscopically or robotically, or in an open operation, we do it at the time of bowel resection. And here's an example. So injection in the subserosa, little bleb brought up, and we do this in 4 sites. Important to wipe away once you've brought the bleb up with alcohol so that you don't spill ICG into the field. And then you've got 5 minutes or so while this develops. This is a quick video of a laparoscopic technique. So we use this connector and a butterfly to inject laparoscopically. So this is us priming and getting ready. The injection itself is done following insertion of the butterfly down the port, and we have this extended connector, so we're able to give the injection from the nursing staff. And here, as you see, it gets dropped into position. We then manipulate it with the graspers. We do this at the beginning of the surgery. And this then gives us sufficient time to begin the mobilization, begin the actual procedure, and allow the ICG to penetrate into the lymphatics. And a similar technique into the subserosa. You can see the ICG now coming up. And it brings up that bleb again. So what else can we tag onto ICG to make it more specific? Because ICG is a very non-specific marker. Well, we've seen some important studies recently, and this is a paper from Hernert and Lancet Oncology, and you can see how you have non-targeted fluorescent agents such as ICG, targeted ones, and then ones that are activatable, which means that you put the dye in, and then there is some sort of primer that activates the dye, giving it its fluorescence properties. And here's an example of the many different types of targeting tissue molecular markers that we can use. So, is this something new? No, it's been going on for quite some time. Perhaps in colorectal cancer and GI surgery, it may be new, but certainly we can look at using smart fluorophores across a variety of different specialties. And this is probably the most exciting one in colorectal surgery at the moment, SGM-101. So this is a fluorescent antibody which goes straight for CEA. This trial is now going through an extended phase 2, phase 3 trial following successful piloting in this particular paper here. And we can see that this particular dye is going to go straight for areas that have a high level of CEA. Another example, here we can see a pelvic sidewall dissection. This is the kind of surgery that we need to be undertaking in those patients that have a pelvic sidewall involvement on the MRI imaging and have undergone neoadjuvant radiotherapy, chemoradiotherapy. We can assess using ICG by injecting straight into the tumor as a submucosal injection. And we can see this in patients that have pelvic sidewall disease. And this allows us to better target and better, more precisely excise these lymph nodes. We can do this with robotic surgery. We can do it with laparoscopic surgery. But one of the problems so far has been that of the depth of penetration of the laser. And as we're seeing an increase level of obese patients, the laser itself doesn't penetrate into the side wall. And if it doesn't penetrate into the side wall, we won't be able to see that fluorescent signal through the fat. So it may be that we need to combine this type of fluorescent technology with other types of technology, such as the use of a gamma probe, use of technetium. And this is a paper in which we did something similar and use a triple targeting technique system, whereby we injected a mix of a fluorescent dye along with colloid and technetium into a patient's tongue to look for a node in the neck. And here you can see us shining the fluorophore onto that node in the neck. And what we see, lo and behold, is hopefully a fluorescent node. And this has already been identified on a PET MR image. And there you are with your fluorescent node. We can think about doing this in the pelvis, because those patients with pelvic sidewall disease, we can give an injection of nanocol as well as technetium into the tumor itself. And then after a period of about 10 minutes or so, we can see that this begins to slowly work its way into the patient. And an optimal timing of a few hours later, we can begin the surgery, use the technetium probe, the gamma probe to find the hot node, and then begin our dissection and allow the laser to penetrate into that area. And we hope to be seeing more of this in the coming months. Why do we do all of these things? And it's really because we're trying to improve our ability by just 1 or 2% at a time. And this is a successful British cycling coach. And he said, if you take any process and divide it up into a series of steps, you can get improvement in each of those steps. And that's what we're trying to do here. We're trying to take a complex surgical disease, break that up into a series of steps, and by using fluorescence to perhaps identify lymph nodes, hopefully improve those outcomes by 1 or 2%, adding to the other 1 or 2% that you've gained elsewhere to give you an aggregated gain of perhaps 10, 15, 20%. Thank you very much for listening.